this particular study set, it covers anything related vascular. So that will include your vascular diseases as well as the neoplastic entities. And the neoplastic entities covered here are pretty much the entities that they test you on your boards. But this is both inflammatory and neoplastic. So let's start with the first one.
All right, so I'll start us out. It's
okay.
like you have, starting from the top down, you have some orthokeratosis. There's a focal area of perikeratosis right there.
Yep.
Epidermis looks largely unremarkable to me. Then you have a superficial perivascular and kind of diffuse lymphocytic infiltrate. And it looks like there might be some leukocyte eclasia going on. So yeah, some scattered, fragmented cytoclastic changes, maybe some neutrophils around the vessels. So I know like LCV we have to think of, but I remember even thinking well, I guess this wouldn't apply to that, but the DH versus the LCV when we were doing the board review. This obviously is not DH, but that was important for even the core exam.
Yep. So yes, so this is LCV, and in DH you would see if it is a LCV mimicking DH, then you would see very distinct subepidermal blister with neutrophils at the tips of dermal papillae. Like it will really look like DH. But then you'll have to go and pay. This doesn't have that, but you will have to go and pay attention to the dermis and look for your vasculitis. So this is just LCV, but yes, that's referred to the pustular variant of LCV, where it tends to form subepidermal pustules, which mimics DH. So that would be the differential. But you described it very well. So this is LCV. And remember, you cannot tell the cause of it from the biopsy. So by looking at it, I don't know whether this is idiopathic, is this drug-induced, was this related to a viral infection or even a bacterial infection? Is it autoimmune related to lupus, Sjogren's, rheumatoid arthritis? Is this Henox-Collin purpura? Is this urticarial vasculitis? I do not know the cause of it from the biopsy. And the presence and absence of eosinophils does not point you towards any cause. In every LCB, we do see some degree of eosinophils. That's because it's a hypersensitivity vasculitis. So you cannot tell the cause of it from the biopsy. And also DIF is not that useful unless and until you want to rule out a Henox-Collin purpura or rule in IgA vasculitis. So in that entity, you want to do a DIF. And the earlier you do the DIF, the better it is. So this is LCV. Good. The next one you're going to do is okay.
All right. Well, doesn't look like there's a whole lot going on here. There's maybe a little bit of superficial perivascular infiltrate there. Maybe some extravasated RBCs. Otherwise, the epidermis looks uninvolved here for the most part. Is this one of our like pigmented purpura-dermatoses?
Or capillaritis, yes. So for all PPDs, a striking feature, as you mentioned, is the presence of hemorrhage. So the even at 4x, if you were to go to 4x, that something that should really stick out to you. And you can easily see that the blood is very obvious and it's subtle. So PPD or capillaritis encompass a group of diseases, all of which share the extravasated blood and some degree of perivascular inflammation. You can have varying other features like spongiosis or some vacuolar alteration or a lichenoid infiltrate. Based on that, you classify it at different times. So like your Schomburg's disease is just your classic PPD, which is this what it is, with the perivascular infiltrate with blood. If you get a predominant lichenoid infiltrate, then it comes in the category of lichenoid PPD or lichen aureus. If it's spongiotic, then it's a spongiotic variant of PPD. Kapinaski, I think it's called something. I always forget that name, but you guys know what I'm talking about. So it can have varying features, but the common feature is lymphocytic infiltrate around the vessels, which is not destructive, so you don't see vasculitis, and presence of hemorrhage. There's often hemosiderin in these biopsies, which may or may not be visible to the naked eye. If you do a Pearl's iron stain, it is present. It's often visible to the naked eye in lichen aureus. So this is a classic PPD. Everybody good with that?
Yep.
Good. It's good.
Let's go to the next one.
We have a subepidermal split maybe here, dense infiltrate in the superficial and deep dermis, extravasated red blood cells.
Yes.
The vessels are clogged.
Yeah.
Yes, so describe to me what all you are seeing. This is not an easy slide, so that's fine. So you want to first go and see the epidermis because it is blistered, right?
It's an acute process, it looks like, because there's an acute stratum corneum. It looks like the vessels underneath were clogged. So whenever it's like a vasculopathy that's causing the epidermis to die and fall off.
Yes. So this is a disease process which often you will get like a second order question with it, or they will try to determine, what do you think is happening to this patient? So, a normal vasculitis or a simple vasculopathy generally does not cause this destruction of the skin. When you see coagulative ischemic epidermal necrosis, which is what is happening in here, because you can see that the stratum corneum is intact, but there is pallor of the epidermis. So the nuclei have lost their pallor. So this is indicative of ischemic damage to the skin, referred to as coagulative epidermal necrosis. This pattern of pallor is what you also see like in a coma blister. So this is indicative of lack of blood supply to the skin. And if you look in the dermis, this is pretty obvious. You see both a vasculitis and a vasculopathy. So there is obviously neutrophilic dust and infiltrate, and you see a beautiful fibrinoid necrotic vessel. So there is a vasculitis, but at the same time, you see that numerous vessels are also clogged. So they are thrombi. So a combination of thrombotic vasculopathy and a vasculitis raises the possibility of entities like, is this infection, septic vasculitis? Is this ecthyma gangrenosum? Is this patient have DIC, purpura fulminans? Severe antiphospholipid antibody syndrome and cryoglobulinemias type 2 and 3 can do that. You also have entities like your levomasol or cocaine-induced cutaneous necrosis and Coumadin-induced, warfarin-induced cutaneous necrosis can also do this. So any of those 8 entities can be as your second order question in this. So recognition of the reaction pattern, understanding the fact that this is not a healthy situation. This patient is sick, and then determining the cause of it. Do you guys want me to repeat those causes?
I got him.
Got it. Okay. So this is more about recognizing the reaction pattern. So good job approaching that. Let's go to the next one. Looks like this done really well. See, there should be another. Looks like we may have to skip the 4. We probably have to rescan it because it's not scanned well. Yeah, we'll have to skip the 4. I'm going to tell him to rescan that. Okay, let's go to the 5.
All right. So we got shape here. Little bit of orthokeratosis up top. And then down in the dermis, pretty busy, a lot of inflammation going on. I see these kind of slit-like vascular spaces spanning across the dermis there, kind of going in all sorts of directions as well. Then a little bit of, I guess, kind of fibrosis or just some collagen down there as well. A lot of extravasated red blood cells. It looks kind of ugly to me, so I would think more kind of along the lines of Kaposi's on this one.
And what's the stain that you will do to confirm that?
HHV8.
Yes. So this is a beautiful example of a plaque lesion of Kaposi sarcoma. So there are interspersed vessels which are normal in here, but then there is obviously proliferation of vessels with a lot of extravasated blood, and which does not make any sense. So you can see, for example, in this field, you have all these empty spaces or lumina without any corresponding vessels. This is because there is a slit-like proliferation of vessels with these kind of blister cells, which indicate the malignant vessels kind of recapitulating the vascular lumina. And promontory sign is often visible in these cases, which is the formation of malignant vessels around a pre-existing normal vessel. So for example, this is a normal vessel right here, but these are all slit-like vessels forming around it. So that's the promontory sign. So these slit-like vascular proliferation, extravasated blood, these blister cells, the promontory sign, these are all consistent with the plaque lesion of Kaposi sarcoma. All forms of Kaposi sarcoma will stain with HHV8. So that's a pretty good stain for this entity. So good job. Let's go to the next one.
All right, so our process here is definitely in the deep dermis, mid to deep dermis. So it looks, I mean, we're kind of like, looks like we're in our square punch differential / big pink ball in the dermis. So I'm picking an angioleiomyoma.
Yes, so you can see here, this is the only entity which produces this dense pink nodular mass in the deep dermis. And there are fascicles of pink spindle cells because they're all smooth muscle in derivation, hence the name leiomyoma with it. But all these fascicles or smooth muscle cells are arising from the wall of the vessel. So there is a vascular component also, which is present in the form of like these slit-like vessels in the dermis. So this is an leiomyoma. Good job. Do not confuse this with an angiomyolipoma. They often throw in there as a distractor. That's a tumor which rarely occurs in the skin. It's the one which is associated with tuberous sclerosis, and it occurs in the kidney. So that's a different tumor. We have the next one. It's the 7th slide.
All right. Well, we are in vascular, so I'm seeing some dilated spaces deeper in the dermis there, which I'm assuming are vascular spaces. It might be on an acral surface there.
Okay.
Think, kind of reminds me of a Mason's tumor versus angiosarcoma. The other one that kind of looks like it.
Okay, so yes, you're in the right category. This is a Mason's tumor. One of the features of a Mason's tumor is not really a tumor, right? It's a reactive phenomenon which occurs either in a pre-existing thrombosed vessel or in a pre-existing vascular lesion. And so the hint of that is often a well-formed thrombus or some kind of an infarcted vessel or a pre-existing vascular lesion. So This one looks like it is pretty well circumscribed, and this may have been a recanalized vessel. So this may have been a big vessel which got thrombosed, and now it's trying to recanalize, and you're having all this vascular proliferation within it. And the hint to that is also this organizing hemorrhage and thrombosis. In angiosarcoma, you wouldn't see areas like this. And then all confined within that pre-existing lesion is formation of this new vascular lesion, wherein you see these intravascular papillae formation, these finger-like structures with hobnail endothelial cells, and the papillary formation. So this is intravascular papillary endothelial hyperplasia or Mason's tumor. So again, the clue for it is go on low power to recognize the circumscription, a pre-existing vascular lesion, the presence of organizing hemorrhage and thrombosis with areas like this is a very nice diagnostic clue for Mason's tumor. Everybody good with that?
Yeah.
Yes.
Okay, let's go to the next one. Like 8th, we have 2 parts.
Looks like we have a really dense like coat sleeve lymphocytes around the vessels here. So it's either like a gyrate erythema.
So what do you think about?
Is there dermal mucin? Looks like there might be mucin in there.
Okay, so what do you think about what's happening to the vessels inside here? So that's a normal vessel lumen. I'm sorry?
Some of them look thrombosed, some of them are patent.
Yes, so this is a nice microthrombus within the vessel. There's another one right here. This one is trying to form one. So, and then let's go and look at this vessel right here. So that's sluggish bud, and that has formed a thrombus in right here.
Mm-hmm.
There's another vessel. Right? So this is thrombotic vasculopathy. And thrombotic vasculopathy can present in varying flavors. Very mild perivascular infiltrate. The problem is inside the vessels with the thrombi, or a perivascular lymphocytic infiltrate, which you described looked gyrate erythema like. That's also is also fine. So it could be subtle to very obvious. Now let's look at the slide 8B. See again, this one too has a very dense lymphocytic infiltrate. There are not many neutrophils, but then when you look inside the vessels, this one is much more obvious. You can see the nice thrombi within the vessels. Yes. So this is thrombotic vasculopathy in opposed to just classic LCV. And the reason and the workup for this is different. So this is associated with the hypercoagulable state. So again, antiphospholipid antibody syndrome, your anticardiolipin antibodies, lupus anticoagulant, cryoglobulinemias, especially the type 1 will give you a pure thrombotic vasculopathy. And then conditions like protein CNS deficiency, factor V latent mutation, prothrombin gene mutation, antithrombin 3 deficiency, and homocystinuria. So all of these entities will produce you an inherent hypercoagulable state, producing thrombotic vasculopathy. So they can either ask you thrombotic vasculopathy, or they can give you a second order question and ask you to recognize the disease. Is that good, guys?
That's good, thank you.
Okay, let's go to the next one.
I've got a punch here. It looks like we have a lot of vascular spaces down in the dermis, quite a bit of inflammation around.
looking at these, they do kind of look a little like slit or crack like spaces, and some of the cells kind of, they look kind of ugly, like a little atypical in the endothelium. So I'm thinking more of one of the tumors. Is this an angiosarc?
Yes. So this is an angiosarc. So angiosarcs, you know, they can come in any varying histology. Poorly differentiated to well to moderately differentiated. Poorly differentiated angiosarcs can be very difficult to recognize and you require stains for it. But well differentiated to more differentiated angiosarcs really do not require any kind of like a stain. You can actually recognize it. You just have to pay attention. So if you were to go and look in this part of the biopsy, this is not diagnostic of an angiosarcoma. It's not at all. Because here you just see a sheet of malignant epithelioid cells, which kind of actually look nested. And you may even think, is this a melanoma or what is this? You do not know what kind of tumor it is, except that it is clearly malignant. You can even see mitosis within the lesion. There is some extravasated blood, that's okay. But the diagnostic part of the lesion lies in recognizing areas which you nicely did, which is right here. So this is slit-like or sieve-like proliferation or a cutting pattern through the dermis and in the fat, which is producing these slit-like spaces. And these slit-like spaces are all malignant vessels, which are kind of eating through the skin. And they're lined by these malignant, really abnormal-looking hobnailing endothelial cells. The adnexal involvement is often a clue, so that this malignant vascular proliferation will go around. So you can see it is involving the sweat glands in here. And the edges of the biopsy are also a nice clue. So you can see the same, the really haphazard zigzag proliferation in kind of like a cutting pattern through the skin. So this process right here is diagnostic for an angiosarcoma. Is everybody good with that?
Yes.
Yes.
And normally the stains that we use for the vascular markers are CD34 and ERG.
What was that last one?
ERG, E-R-G.
ERG, okay.
Okay. This is slide 10.
Okay, so we got a busy dermis here. Epidermis looks okay for the most part. It's orthokeratosis, but I think the main action is here in the dermis, superficially mainly, but also extending deep. It looks like you have some neutrophils in there. From what I can see, it looks a little dirty. Potentially some lymphocytes as well, but I think this might be another LCV. Looks like you have some on the vessels.
Yep. This is another very nice LCV. You can see the beautiful leukocytoclasia with a lot of nuclear dust and hemorrhage. And then you can see the fibrinoid necrosis of the vessels. So they are basically being chewed up. So this is just an example of another LCV. Good.
Awesome.
Let's go to the next one. You guys can direct me where you want to go.
Well, it's like there's quite a bit of hemorrhage there throughout the dermis. I can't tell if within the adipose tissue there's a larger thrombosed vessel in there, maybe. When I see that, it makes me think of something like polyarteritis nodosa or like an erythema induratum.
Yeah. So this is so this is PAN, and that exactly will be in your differential. But PAN is very different from E induratum in the sense both of them produce you a lobular paniculitis. But E induratum is multiple vessel, multiple nodules, whereas polyarteritis nodosa is just one vessel, one nodule. So you can see that the biopsy kind of like always tapers to the involved vessel. And you can see that there is one vessel involved in here, which has got beautiful fibrinoid necrosis. This happens to be a medium-sized vessel, and there is spillover of the inflammation into the adjacent lobule. So this is cutaneous PAN. You can see the nice destruction of the vessel in over here. So good job. And this is all procedure-related hemorrhage. So whenever we see red blood cells without any much corresponding inflammation within it, that is procedure-related. So great job. Next one.
Shade biopsy here. Lots of vessels up at the top, some hemosiderin and red blood cells that have been extravasated. There's lots of vessels and the walls look really thick, but they look patent.
Yep. So these, you can see that the epidermis is also pretty thick, and all of these vessels, they're pretty lobulated, well circumscribed, and they look like what?
Just like glomeruloid.
No, this is just stasis derm. So you can see this nice thick wall lobulated proliferation of vessels, like these kind of like cannonballs like thrown out in the dermis. And it's not uncommon to see chronic blood and hemosiderin in these lesions. So this is just stasis derm. The nice clue to it is always the thick epidermis, along with this lobulated proliferation of thick wall blood vessels, which look like little balls scattered out in the dermis. Is that good, guys?
It's good.
Okay. Okay.
All right. Looks like we have quite a bit of inflammation throughout the deep and superficial dermis here. Primarily located around the vessels. Let's see. Some of those vessels look like there's a little bit of vasculopathy going on there. A little bit of, there's newts and lymphocytes around some of the vessels, so kind of an LCV type picture as well. What's the
Good job. You're doing a great job.
Some sort of LCV type process.
So you said LCV and vasculitis and vasculopathy, right?
Yeah.
In the background of
with like stasis change as well.
Yep.
So
and an ulcer.
Atrophy blanche.
Yep. So stasis ulcer with atrophy blanche or livedoid vasculopathy. So this slide always looks extremely busy because you can see there's often an ulcer, there is stasis change, but that, as you nicely mentioned, that within the lobulated vessels itself, you will see, so it's one step beyond stasis derm. You will see the nice thrombi within the wall of the vessels, but also thick walls with an associated vasculitis. It's a combination of both. So that's atrophy blanche. So great job picking that up. Everybody good with that?
Yes.
Okay.
Okay, so. We have a shave here with a very thin stratum corneum. Um. hmm, Essentially on the face, so we see some, so some vessels that are thrombotic, so they're plugged there. And then surrounded by dense collections of lymphocytes.
Mm-hmm.
Here, what could this be? Some EOs.
Mm-hmm.
Where's it? Geo. So I guess with the EOs and the lymphs, and it's really busy. GF comes to mind.
What is the one thing lacking for GF in here, or two things?
You don't have many newts from what I can
Mhm.
see.
And there is
And
no vasculitis.
no vasculitis.
But instead, so there is limbs and eos. You said they are hyperplastic limbs and they are eos. And then do you
Oh,
see these vessels?
yeah. Is this ALHE? I always want to say AHLE. Yeah.
ALH, angular lymphoid hyperplasia with eosinophilia. And the clue for that is this. The vessels which have prominent hobnailing endothelial cells, like they're sticking out in the lumen.
Mm,
That's why they look like thrombos to you, but they are not. It's just
yeah.
really prominent endothelial cells with lymphoid hyperplasia and eosinophils. So this is like your very classic ALH eosinophilia, which occurs in the skin. There is
Perfect.
another example we have in here, which is this, I believe. So you remember those vessels that you saw in the skin?
Yes.
You see, these are the same vessels. You see that?
Yes. They're
With the
slit like
prominent endothelial cells? Yes. The hobnailing, you see that?
yes.
And then there is background lymphoid hyperplasia. And you see all these EOs?
Mhm.
So this is a subcutaneous variant of it. So this could fall in the category of Kimura's disease.
Okay.
So this is good. This is much bigger. So it often presents like a mass lesion, either behind the ear or in the, around the region of the parotid gland. They can present with lymph node masses, parotid gland swelling. So the histology is the same. It's the angiolymphoid hyperplasia with eosinophilia, except that this occurs in a specific ethnic population and is associated with systemic symptoms. So there is peripheral blood eosinophilia and often an increased IgE. But the cells, the lymphoid hyperplasia, the eosinophils, and the vessels with these prominent hobnailing endothelial cells, they look the same.
Got it. That's good.
Good. So compare this slide to this, because I think the key that I want you to recognize, if you recognize these vessels, the diagnosis becomes very easy, because then you're like, oh, there's lymphocytes and there are eosinophils. It's a combination of that. Arthropod assault wouldn't give you the vessels, and GF wouldn't give you the vessels, and in GF you get neutrophils. Okay, so which number was that? Was it 12?
That, yeah, that was 14.
14. Okay, so you have to go to 15.
Well, it looks like, most of the infiltrate here is really
Mhm.
superficial papillary dermis.
Yep.
Looks like most likely acral skin here. And it looks like there's some newts probably around superficial vessels there. That combination of things.
So believe your eyes. What is the most prominent feature of this biopsy, which is really striking out to you?
I guess newts in the dermal papillae, which
Newts in the dermal papillae. Where are you seeing newts? Are you referring to these cells?
I thought from high power, but they look
Okay.
more lymphs, I suppose.
Exactly. Yes. But even more prominent that, other than the inflammation, what is striking out to you?
There's some superficial vessels there. I guess kind of that it's just well defined. The infiltrate's just really well defined to the dermal papillae. Is what
Okay, take a step back and see. It will come to you. Anybody else find something in this biopsy which is very striking?
There's some like RBCs within the stratum corneum.
Exactly. Yes.
Okay.
There is a lot of blood. There is
Yeah.
blood in here. There is blood in the epi, and there is blood in the dermis. You see that?
Yes. So
And now put all of this together. So what you described, the pattern of the infiltrate is what?
superficial lymphocytic perivascular
And lichenoid, right?
and lichenoid, yeah. So is it kind of one of our lichenoid PPDs?
Yep, this is lichenoid PPD. And it always appears very busy on low power. And it is not really destructive to the epi, but the pattern of inflammation is superficial and lichenoid, and the blood really stands out. This one happens to be close on the foot area, and that's why the blood has this is like a really exuberant variant of it, because normally you don't see blood leaking out into the stratum corneum, which in this case it has.
Gotcha.
Okay. The blood is a very, very important clue, and trust me on that. It is a really important clue for PPDs.
Okay. Good.
Okay. The slide 16.
Got a punch here, lots of extravasated reds. Let's see here. Oh, this, so the vessels are, clogged here. This is thank you, calciphylaxis.
Yes. So the point I was trying to make is that this is not healthy fat. Does this look healthy fat to you?
No.
No, right? So this is undergoing, this is like, fat is like, please try to save me. It's like dying. And in the background of something destructive, when you see vessels which have got calcium in them with hemorrhage, and there is subtle, very subtle microthrombi being formed in these tiny fat vessels, that's very consistent with calciphylaxis. So you need to see evidence of tissue damage besides seeing calcium deposition in the wall of the vessels. So good job. Okay.
All right. It looks like we have kind of like a lobulated growth extending up from the surface of the skin there. The top surface looks kind of crusty and kind of gross looking up there. In this lobulated growth, there's a lot of vascular spaces surrounded by, looks like a lymphocytic inflammation. There is that little collarette coming down from the epi on that side though. So I would think this is a pyogenic granuloma. Yes.
If you don't see pyogenic granuloma and capillary hemangiomas, they will look very same. The other name for a pyogenic granuloma is a lobular capillary hemangioma. It's often difficult to distinguish between the two, so we largely rely on the clinical. And also on, yes, as you mentioned, the ulceration and the collarette is a nice clue that this is likely trauma-driven vascular lesion, which would be consistent with PG or a lobular capillary hemangioma. Good job. That's a very important board question. Slide 18th.
There looks to be, it looks like the upper third half of the epidermis is dead or dying.
Mm-hmm.
And in the presence of this vasculopathy, I would just call this like a coagulative necrosis.
Yep.
Um,
With the cause of it is what? There is both a
thrombotic vasculopathy. Sorry, I can't talk.
and vasculitis. Yes.
And vasculitis.
Yep. So again, any of those 8 reasons can come into the picture. So DIC, purpura fulminans, septic vasculitis, ecthyma gangrenosum, severe APL, cryoglobulinemias type 2 and 3, liver mesol cocaine-induced, and your coumadin-induced necrosis. And this is, again, I'm really hammering upon this because I want you to recognize this pattern. This is often a clue. So even if somebody did a shave biopsy and I saw this kind of skin, it would worry me in the appropriate clinical setting, because this is the pallor in the epi, which is indicative of something much more significant in the skin down. And you can see that the vessels absolutely here do not look healthy. The neutrophils are always poured into the unhealthy epi because they're going to try to get rid of it. So that's something that you see as a part and parcel because of the dead skin. So great job. And we have the next one. Okay, this one is a difficult one, and I largely put this in there for completion of my vascular tumor set. So the vascular tumors that you get tested on are either benign or malignant. So among the benign entities, you have your common ones like your pyogenic granuloma, capillary hemangioma, glomangioma, lymphangioma, what else? Hobnail hemangioma, rarely. And then you have your malignant tumors is your Kaposi sarcoma, angiosarcomas. And then you have mimickers like your Massan's tumor. And an intermediate malignant vascular tumor, so in between a benign and a malignant vascular entity, are tumors which are referred to as hemangioendothelioma. So and in the word omas, hemangioendotheliomas, and those are of 2 kinds. Those are the Dapska tumor, which the other name for that is a papillary intralymphatic angioendothelioma, or PILA, and the other one is a retiform tumor or retiform hemangioendothelioma. So those words can be distractors in your multiple choice. Hemangioendotheliomas are not benign, but they're not as aggressively malignant as an angiosarcomas, but they are malignant tumors, so they need to be excised. So they present as these kind of plaque-like vascular lesions, where you again see vessels which are diffusely cutting through the dermis, but they're not malignant looking like angiosarcomas and not destructive as much as angiosarcomas. These are not easy diagnoses to make. Even soft tissue experts may sometimes, be confused with these entities. I put this in there largely for completion. So this is a tumor which obviously is diffusely cut off at the base, would require excision. So this would be signed off as a hemangioendothelioma. And remember, there are 2 kinds of it. It's the Dapska tumor and the retiform hemangioendothelioma. Okay. All good?
Yes,
Yeah.
thank you.
Okay, next one is your 20th tumor. This one will be asked, and the diagnosis here is?
Lymphangioma.
Yep. So lymphangioma circumscriptum, and cystic hygromas will all look the same. And they are lymphatic in derivation. So you can see these nice dilated structures, which are all lymphatics, which look like little blisters juxtaposed to the epidermis. You have valves and you have the pink fluid. So that's a lymphangioma. Good. Lymphangioma circumscriptum often has epidermal hyperplasia overlying the lymphatic, and there is supposed to be a feeder vessel in the deep dermis, which we may not always see. But the vessels look the same. And so also in cystic hygroma, which is a congenital lymphatic malformation. So this is a kid. So what is this?
Oh, let's see here.
It's a nice lobulated proliferation.
Yeah, it's just a hemangioma.
It's just a hemangioma capillary type. There's often a feeder vessel, and then you can see the really nice small spaces which are filled with blood, but the lumen are not very distinct because they are capillary sized vessels. But if you were to do a stain, it would highlight the lumen and very, very well. So this is a capillary hemangioma. Okay. This is going to be in contrast to like your salmon patch or your port wine stain, which don't show a vascular neoplasm. They're just telangiectasias. Within those, you may get capillary hemangiomas, but these are different vascular lesions in kids.
Is the central cleared out space just a double check? It's just artifact.
This is artifact, yes.
Okay.
We didn't get a complete section. Yep.
Gotcha.
The next one is your 22. So that was a capillary hemangioma, and this one is a
like a venular hemangioma?
or a cavernous hemangioma.
Cavernous, okay.
Okay. We have the next one is 23. So these are group of vascular lesions which are benign, but they interestingly show these kind of ectatic vessels which look like basically like a telangiectatic hemangioma, dilated vessels. But within the lumen of it, you see this kind of hobnailing and micropapillae, like these tiny finger-like formations. You see that in here?
Mm-hmm.
There can be some background intraluminal thrombosis within these lesions. So this kind of a phenomenon, basically you can just see in a normal telangiectatic hemangioma, and we don't even mention it. But it's also seen in type of hemangiomas known as hobnail hemangiomas or targetoid hemosidrotic hemangiomas. Targeted hemosidrotic hemangioma is more of a clinical description of what you see. One of you guys working with Dr. Crane had a nice case of targeted hemosidrotic last week. I saw a biopsy from you guys. It was in a kid. It was a lesion on the leg, and you guys described it like really well. The picture looked really targetoid. You probably thought it was something like a nevus. I'm forgetting that case, but that was a great example of a targeted hemosidrotic or a hobnail hemangioma. So targeted hemosidrotic hemangioma is more of a clinical descriptor of the hemangioma, and hobnail hemangioma is more of a histologic descriptor. So we either do not comment on that at all. We just throw it in the category of hemangiomas, but we mention it if you guys correlate it clinically. So that is why it's a board testable entity for your board. So you will see these telangiectatic vessels, but the pathognomic feature is the presence of these prominent hobnailing endothelial cells with these finger-like proliferations. And there may be also some background thrombosis. So this is a targeted hemosidrotic or a hobnail hemangioma.
A good one.
Yes. And this kind of a phenomenon can also be seen in another tumor, which is basically this. This is also another benign vascular tumor. And I'm again going to mention this because you guys are smart and I want to complete my benign vascular tumor set. But it's an interesting tumor. So this one, as you can see, it shows the same telangiectatic vessels, right?
Yes.
And it has the same hobnailing and those micropapillae formation, those fingers, right?
Yes.
Right.
This entity, however, clinically does not look like a vascular lesion to you guys. It often comes in as a nevus or a PCC. And the classic location is on the chest of females. Females are pretty, because they think that there is some kind of like a hormonal association with these entities. And the classic finding of these entities is that these vessels, they grow around like adnexal units. So you can see like the sweat glands. And one of the things is the involvement of the erecta pili muscle. So there is, I think, my dot in over here, I think, which shows that. So you can see actually the vessels. This is the erecta pili smooth muscle. You see how the vessels are involving it?
Yes.
This is a microvenular hemangioma. This is a common mimicker of like a low-grade vascular malignancy. So you'll worry like, is this a KS? Is this a hemangioendothelioma? But in context of the clinical and these classic findings, which I described to you, this is a microvenular hemangioma.
That's a good one.
Yes. So that is pretty much in your benign vascular things that they can ask you. I will highly doubt if they ask you a microvenular hemangioma, but that hobnail and targeted hemosidrotic is a pretty good one to ask. Okay. Slide number 25. This is an important entity, which I don't know if it really lies in your vascular tumors, but it's something that you will definitely get tested on your boards. And I want to see how you approach this slide.
Well, looks like we kind of have acanthotic epidermis there, maybe on acral surface. We have some more ectatic vessels.
So it's not, let me tell you, it's not acral surface. It's just irregularly thick.
Okay. Got
Okay.
thick skin and some ectatic vessels there. I don't know.
And what do you think about the dermis?
It's almost like fibrinoid or kind of sclerotic.
Exactly. Sclerotic is the right word, right? So it doesn't look normal.
Not.
So in the setting of a sclerotic dermis, and what did you say the vessels were?
Ectatic?
Yep, do they look normal?
Oh, no.
Not at all, right? They are varying in size and shape. They have some kind of a thrombus, ectatic, however you want to describe them. Some are small, some are big, variably sized. A combination of abnormal looking vessels on a sclerotic dermis with
Maybe like a radiation dermatitis?
exactly. This is radiation dermatitis. So when you see this kind of a homogenized, halonized, sclerotic, whatever you want to call it, dermis, which looks like bright pink like that, and you see all these abnormal vessels. And this one is also really nice because you see fibroblastic atypia. So radiation can produce that. So this is a beautiful example of radiation dermatitis. Okay?
I like it.
Okay.
Hey, can I tag you on Instagram to shout you out for teaching us?
Oh, that would be great. Thank you so much.
Yeah, definitely.
Thank you.
Thank you.
Okay, slide number 26. So this, the blurry slide was the same disease entity, but a different slide, but I'll get that scanned for you. So let's see if you guys can figure what this is out. There is a incidental finding also on this slide. So if you guys want to talk about that as well, that will be good. But that's not the primary thing. So I'll show you both the biopsies. So it's this. This is an incidental finding in here. And it's this.
This is kind of, oh, sorry. This is kind of reminiscent of me of a microvenular hemangioma. Is this an acquired elastic hemangioma?
So an acquired elastic hemangioma never has inflammation. And
Okay.
the classic location of acquired elastic hemangioma is your extremities, especially the arms, the sun-damaged skin. The most striking feature of an acquired elastic hemangioma is actually going to be solar elastosis. And then within the solar elastosis, you will see vessels popping up. So it clinically actually never looks vascular. It will come in as like a reddish patch or a papule. So you clinically don't really know what it is. It comes in as a BCC, non-melanoma skin cancer. So tell me, first of all, what the location of this entity is.
Face.
Face. So acquired elastic hemangioma would be a bad location for that, and so would microvenular hemangioma be. When you go up on high power, what do you see?
You see leukocyte
Mm-hmm. Mm-hmm. Yep.
I was thinking it was EED because it almost looks like onion skinny look to it, and are there EOs in the background?
What's the sister of EED, which occurs on the face, which is this?
Yeah.
GF. So this is granuloma facial, and you can see that there is actually so often granuloma facial are older people, right? So even though you have a Gren zone, which is very good in this, you often sometimes will have coexisting acne keratosis. That's not uncommon. And then you have a surprise finding in this one. This is a small what? So really tiny. It's so tiny that it's probably not even worth commenting, but you can see that this is
TFI.
it's a TFI. You can see these plates arranged parallel with the palisading and the pale. It looks paler as compared to your normal epi. Guys, hold on 1 minute. Hello? Hello?
So what's in general?
You guys are crushing.
Did I tell them? I got some social very small.
Yeah, you guys are both crushing.
You're small. Oh my. We were talking about the sports guy. I was like, trust me, Kay knows.
Sports, yes, I will back you
We're
on that.
small. But also life. Yeah, life small.
Well, I grew up.
We'll see when.
Okay, sorry about that, guys. So do you see the GF in here now?
Yes.
So you can see the nice Gren zone, and you can see these vessels with the mixed infiltrate. There is leukocytoclasia and eosinophils, and you can see the vasculitis in there. Now, the thing about EED is that EED, you guys can like clinically gets missed for quite some time. So by the time you biopsy it, that's why you get the onion skinning, because the inflammation kind of subsides. Whereas GF is often biopsied in its fresh phase, but it's not uncommon for the infiltrate to be either in the very primitive stages where it is diffuse, or it's predominantly concentrating around the vessel. So this is why it gives you the appearance of that onion skinning, but that is much more prominent in an EED as compared to GF.
Cool.
Okay. So that's your granuloma facial. 27 we did, that was your ALH, eosinophilia, or Kimura's disease. You have your 28. Okay, this guys, you should be able to know this.
All right, looks like we've got a bunch of inflammation around the superficial and deep vascular spaces, as well as some eccrine glands there. There's some inflammation around them. It's probably lymphocytes. So when we see that around vessels and glands, eccrine glands, we think of tumid lupus. I think you can also see it in the gyrate, erythema gyrate.
Yes. So the reason this one was there in your study set is because the pattern of the coat sleeving, which is seen in tumid lupus or in the gyrate erythemas of the EAC kind, you in the olden times, that tight coat sleeving was described as lymphocytic vasculitis. That term is obsolete, though it's still used by some authors, largely from Australia and from the European countries, but I don't like that term because it's misleading. There is no vasculitis in there. It's just a tight infiltrate around the vessels. But when they are referring to that, they're actually referring to those entities. This is tumid lupus, because you have the nice superficial deep perivascular periadnexal lymphocytic infiltrate, and there is beautiful mucin. Obviously, the difference would be from EAC, which is the only both testable entity, not the other gyrate erythemas like erythema gyratum repens, erythema chronicum migrans, erythema marginatum, congestionous lymphocytic infiltrate, because there is nothing classic about the histology of the slide. They have some degree of epidermal changes in context of the clinical. So this is tumid lupus because of lymphocytic infiltrate and the mucin. Good. You have the 29. It's on the lower extremity.
Yeah, it looks like you have some cannonball vessels.
Yep.
And some extravasated reds. Is this just more stasis?
Yes, this is stasis derm. Great job. Or acroangiodermatitis. Remember, they can often just throw that in there. That will look exactly like stasis derm. Slide number 30.
I guess we have a pretty deep vasculitis here, multiple vessels,
Mm-hmm.
extravasated RBCs. Is this more of the erythema and sort of scenario? Okay.
Yep. So this is a lobular paniculitis, but you see multiple vessels, multiple lobules. And there is clearly a vasculitic process. So this is E induratum or nodular vasculitis. And what will be the second order question that they ask you about this? What is the disease entity it's associated with? The two diseases?
TB.
And Hep C. Great job. We have the next one, which is slide 31. Okay, this one is difficult. I'm going to explain this to you. And again, I have put this in there for the completion of your study entities. I really haven't done cutaneous lymphoproliferative entities with you, right?
No, I don't think so.
Yeah, so maybe I think I would do that. I would require like definitely 1.5 hours. So maybe the next time we can basically do that. It's like a PowerPoint with slides. So whenever you see a lymphoid infiltrate, which is obviously destroyed the skin, you can see the nice epidermal necrosis, but it's tightly around the vessels. That vasculocentric infiltrate can produce you a secondary vasculitis. So there is a vasculitis in here. You can see that all these vessels are actually destroyed, but you can see that these lymphoid infiltrate, these lymphoid cells don't really look healthy. Do you guys agree?
Yes.
Yeah.
It looks pretty bad. So a vasculocentric process is most often a T cell driven process. So if you were to stain this entity up, and then I gave you a second order question with it, that this is CD3 positive, CD30 positive, what's your diagnosis?
Lymphocytoid papulosis.
Yes. So this will be CD30 positive driven T cell process is a CD30 positive T cell LPD. And pretty much what does that is not anaplastic large cell lymphoma, because that's a sheet of atypical cells. This would be your angiocentric variant. So it's not A, it's not the type A LYP, not the type B, not the type C. It's a type E variant of LYP, which tends to be vasculocentric and vasculodestructive. The caveat being, always remember that if you are seeing a vasculocentric T cell process, it's important to exclude out Epstein-Barr virus-driven T cell lymphomas. And the other entity which can do that, which is not CD30 positive, it's a T cell process which is EBV driven, is your extranodal natural killer T cell lymphoma. And there is another entity which is also EBV driven, which does that, is angioimmunoblastic T cell lymphoma. So all those entities that produce secondary vasculitis, most often they are associated with EBV infection. The anomaly among that is your type E LYP, which has got nothing to do with EBV and is CD30 positive. So I threw a lot of words in here, but after I'll do the lymphoma topic with you guys, it will be much more clearer, because that's one of the first things that I teach you about T cell lymphomas, is how to classify them, under the microscope, which is either epidermal or around the vessels or in the fat. Okay, so this is the next tumor. What is this? This is a common tumor. They'll definitely ask you this.
It looks like there's glomus cells in there, so is it glomus tumor?
Or a glomangioma. So it's not necessary to differentiate between a glomus tumor and a glomangioma. If it has a prominent vascular component to it, we often call it a glomangioma. These are all glomus cells which are myoid in derivation, so derived from the muscle cells around the endothelial, the vessels. So they will be SMA positive. So good job. So small, round, again, monotonous proliferation of cells associated with the vessels. So just slide 3.
All right, got a little bit of acantholysis going on up top. And then the superficial dermis, we have inflammation of the vessels. Maybe a little bit of extravasated red blood cells as well. Looking at the vessels, I can see lymphocytes.
What is like this? Did you mention this?
That looks like a little pustule, like a subcorneal pustule, or not subcorneal, but.
And what does this remind you of?
Subepidermal pustule, yeah. It reminds me of like DH, like a bunch of new there in the dermal papilla. It looks kind of dirty around the vessels, like debris. So it looks kind of like an LCV type picture.
Yep. So this is where Jared was mentioning that this will come on your boards. You will be very tempted to pick up DH and that will be in your differential. But this clearly isn't DH. This is actually a pustular LCV or just an LCV. So it's important to pay attention to the vessels, which you did. Okay.
I can't remember what I wound up picking, but I want to say I actually wound up picking DH, but I don't know. I know I didn't like. Yeah, I don't know, but it was so confusing. I spent way too long on that question.
So it's a very a common mistake to make because because the blister really looks so much like DH. Like you're so tempted to do that. But if they have DH and LCV in the differential, your diagnosis, they are testing you on LCV. They're not testing you on DH.
Okay.
Because otherwise there is no reason for them to put that in there, right?
Yes.
Okay, 34. Again, this is like instantly when you see it, you should know it.
And you start?
Yeah. Everybody sees the slit-like sieve vessels?
Yes.
That's diagnostic, doesn't need any stain. And then this last one also instantly when you see it, you should know it.
Yeah, I should know.
So it's a nodule, right?
Yep. Got a pretty well circumscribed nodules, extravasated RBCs, and some vascular spaces. Is it nodular Kaposi's?
Yep. So not like Kaposi's on low power actually doesn't look like a sarcoma. It will look like a well circumscribed lesion. The cells also don't look like that ugly, but you will see extravasated blood and slit-like spaces and these kind of blister cells.
Nice.
So that's all your malignant vessels trying to recapitulate the normal vessels. And there are lots of extravasated red blood cells in between them. You often see plasma cells also within the infiltrate. They have been described. But honestly, when you see a nodular proliferation of spindle cells with these kind of like these slit-like spaces and the blister cells and blood, that's nodular KS. Okay. I was
Awesome.
trying to see if I have an acquired elastotic hemangioma lying around somewhere here. So give me a minute.
Okay.
If I can find it, I will show it to you. Otherwise, I will show it to you next time. We didn't cover an angiokeratoma, but everybody, you guys know what it looks like, right?
Yes. I just want to give a shout out to our first years. No
Yeah.
second year today, so just Chiefs in our first years, and they crush it.
Yeah, they did. This is a difficult topic, and you guys did actually really well, and I'm really proud of you all. Let me see. I think give me just one more minute. I'm. As soon as I get off, I'm sure I'm going to find it. Nope, I'm not finding it. I'll get it for you guys next time.
No problem.
Okay, so I think we'll do lymphoproliferative disorders next time.
Good, thank
Okay.
you.
Okay, great.
Perfect.
Thank
Thank you
you.
so much.
Thank you. Have a good day.
Thank you.
Yeah.
Bye.
Bye.